So we're going to change it up a little bit. I don't see Dr. Milsom on the call. He was getting off a plane. So we're going to go with Dr. Chow if he's ready. Dr. Chow is an assistant professor of surgery in the Department of Surgery and one of the three surgeons at New York Presbyterian in Queens, working with Dr. Foglia, with Dr. Patron, and collaborating in research with our group here and doing a lot of great work in Queens as well. So Dr. Chow will be talking about how do we bring our state-of-the-art colorectal cancer treatment to the community.
Great. Thank you, everybody. Thank you, Dr. Ficara.
We can see it.
You can see it. Great. Okay. My name is Steve Chow. I'm one of the colorectal surgeons here at New York Presbyterian Queens. And thank you so much for the introduction, Dr. Ficara. Thank you so much, Dr. Yo, for the nice segue, the nice presentation that kind of conveniently segues to mine. So how do we bring our state-of-the-art colorectal cancer treatment to the community? Some disclosures. Some of this was funded by the grant from the NCI. I'm a colorectal surgeon from Queens, and I'm from Queens too. It's the New York City's largest and most diverse borough, home to over 2 million people and more than 150 languages. Queens is truly a global village. Whether you're here for the food, the people, or the vibe, one thing's for sure, Queens doesn't just represent New York, it represents all of America. I'm probably underselling this, but colon cancer surgery is hard. It usually involves a resection of both the affected colon and adjacent lymph nodes. Um, it's a surgery that's prone to complications. Complication rates are cited range from 15 to 30%, which include wound or organ space infection, anastomotic leaks, obstruction, blood clots, pneumonia, and urinary tract infections. And so back in the 90s, Dr. Foglia mentioned this briefly when we were doing a lot of open surgery. The average length of stay for colorectal resection was over 10 days at the start of the 90s. And in 1995, a surgeon from Denmark, Dr. Henrik Kalet, published in The Lancet about his idea of a fast-track pathway by integrating evidence-based practices to minimize surgical stress, reduce complications, and expedite patient recovery. His average length of stay was published at an average of 5 days, which was pretty revolutionary at the time. The so the history, the little history of the enhanced recovery after surgery protocol. In 1995 was the original publication by Dr. Kalet, and then in 2001 there was the creation of the ERAS study group, which later became the ERAS Society, in which this was created with a mission to develop perioperative care and to improve recovery through research, education, auditing, and implementation of evidence-based practice. And then in 2005, there's the first evidence-based consensus protocol. And in 2013, the first ERAS Symposium was held in the US. In 2017, the JAMA Surgery published a review article about and highlighting the important points of enhanced recovery after surgery protocols. Enhanced recovery after surgery is a patient-centered, evidence-based approach to surgical care that helps people recover faster and with fewer complications. The whole is greater than the sum of its parts, in that many small interventions can have an additive effect. It involves optimizing every step of the surgical journey before, during, and after surgery, using things like better pain control, with fewer opioids, early mobilization, and improved nutrition. The goal is to reduce stress on the body, shorten hospital stays, and help patients get back to a normal life sooner. And so when I started in New York Presbyterian Queens, it was right around the time when the JAMA surgery review article was published. So I joined the Presbyterian Queens in 2016 as a colorectal surgeon, and I was incredibly lucky and blessed to be hired in a hospital in the neighborhood which I grew up in. And I always wanted to bring the latest and best of care back to a community that raised me. So I wanted to help implement an ERAS protocol here in New York Presbyterian Queens. And I thought it wouldn't be that difficult considering so much research had already been published, and I thought I was already given a map and just had to follow the directions. So in 2017, we initiated our ERAS protocol here in Queens, and we essentially copy and pasted the ERAS protocol that was published in other, manuscripts, which included preoperative a protocol, including medications, bowel preparation, mechanical and antibiotics, special soaps, and a special diet beforehand. Uh, Pre-op and intraoperative medication changes and algorithm changes with our anesthesia colleagues, and postoperatively really encouraging patient buy-in and understanding that they need to get out of bed. They need to kind of an aggressive escalation of diets postoperatively. But I essentially copy and pasted the ERAS protocol. However, in the first year, we weren't really seeing the results that we were hoping and expecting. The length of stays weren't really changing all that much. The complication rates weren't all that different. And so why was that? So this is a comparison of Denmark, which is the original patient population that which the original ERAS manuscripts were based on, in Queens. So you can see it's like dramatically different. In Denmark is 96% native Danes. In Queens, we're definitely nowhere near 96% of anything. 92% of people in Denmark speak Danish. And here in Queens, over 800 languages are estimated to be spoken, with over 56% of residents don't speak English at home. They have universal health care in Denmark, while 33% of our non-elderly adults are uninsured here. And there's a 99% literacy rate in Denmark, while it's an estimated 79% literacy rate in New York City. So, so why is this? So, this is kind of a common trend. Like a lot of state-of-the-art research is done in Europe and in America, but they don't really fit the patient population of certain communities like Queens. So this is kind of a retrospective review of overview, but in American colorectal cancer surgical trials, 66% of papers didn't report race, and 73% did not report ethnicity at all. And when they did, the overall pool population, the minorities were grossly underrepresented, with pool portions in surgical trials of 81% white patients, 6% black patients, 3% Asians, and Hispanics were only 3%. This is especially concerning considering what we just heard from Dr. Yo, is that patient populations facing the greatest barriers to accessing state-of-the-art colorectal cancer care are those in the racial and ethnic minorities, people with low socioeconomic status, the uninsured, the underinsured, residents in rural areas, older adults, and those with multiple comorbidities. So, the data out there in high impact journals and in surgical trials is grossly underrepresenting a very important part of what contributes to healthcare outcomes. And minorities are also represented. Dr. Yo has done a lot of good research on this too. Minorities and women are historically and significantly underrepresented in medical and cancer research. Only 1% of NIH and NCI funding is awarded to Black scientists, 5% is awarded to Hispanics, and less than 2% of all NIH funding is dedicated to research of diseases specific to minorities. And I think this problem is only going to get worse in the next few years. So the task was to find a way to make ERAS work for the people of Queens. Language and health literacy was our main barrier. Queens is the most diverse urban area in the world. Over 56% of people don't speak English at home, and over 47% of our residents and our patients are immigrants. I really like this map because it just shows like a general neighborhood, and it looks like a map straight out of Lord of the Rings, but you can see all the different languages in the different neighborhoods all throughout Queens, and to really kind of pinpoint the challenges we face. And that's where we are in Queens, right there, right in the middle of all this explosion of different languages and dialects. The preoperative medication bundle that's required in ERAS includes like antibiotic and mechanical prep, soap, nutritional supplementation. First of all, not all local pharmacies carried all the necessary components. I can count. It's a really common issue that not many pharmacies carried neomycin or just regular Ensure or things like that. And even if they did, the entire bundle was really heavy and difficult to carry for patients, especially geriatric patients to carry. Why was this an issue though? Well, like about 55 to 66% of our residents don't own a car, and our hospital is located right here, which is located in a public transportation desert. So much so that the legend for this MTA map is like covers most of our catchment area. It's 1 mile away from the nearest subway station, and most residents rely on walking or buses, which require many circuitous transfers for their daily transportation needs. So So these are all the issues that we were faced with, kind of a brief summary of them. And these were issues that I really hadn't encountered in my surgical training, and it certainly wasn't encountered in the original publications on ERAS from Europe and America. And what we realized is that these original papers were all from really homogeneous, high-resource academic sites. So we needed to tailor it for our patients in Queens. We needed to do it in a patient-centered, culturally sensitive, and with a focus on health equity. This idea recently of socio-precision surgery or medicine is a concept that integrates social, environmental, structural, and behavioral factors into surgical decisions. And we hoped to kind of integrate that in our ERAS protocol. And so we partnered with the local pharmacy, Nexia Specialty Pharmacy, to deliver preoperative medications within 48 hours. This was an option offered to patients to help eliminate the burden of transporting the heavy and cumbersome preoperative medication bundle. We changed our instructions. We added visual cues and colors to help understanding how to take those medications before the surgery. And we translated all these instructions in the most common languages spoken in our catchment area, which includes Spanish, Chinese, Korean, and Russian. We gave patients an opportunity to talk with a member of our colorectal surgery team with a certified interpreter to go over all the medications and how to take them. And they would have time to come in with the caregivers and ask questions and clear up any misconceptions or any issues that they would have. And so we published on this. Julie Hong, one of our awesome surgical residents, published this a couple of years back, and we showed that with this tailored approach, we showed that we got some good results. So the length of stay for overall enhanced recovery patients was over a day shorter. So we had a length of stay of average of 4 days, as opposed to people who didn't undergo ERS had a length of stay of over 5 days. Among the people in the ERAS group, there were about 300 patients in the ERAS group. About 205 patients got the delivery option. And just comparing the delivery options to the no ERAS patients, the delivery option patients averaged a little less than 3 or 4 days actually in the hospital, while the patients who didn't undergo ERAS at all was over 5 days. And people who underwent the ERAS protocol were a lot less likely to be discharged to a nursing facility postoperatively. This is a question that Chris Foglia and one of our residents who graduated, Angelina Kim, did, which, did it help with disparities in terms of time frame? The idea of a weekend effect was something that we were interested in. Is that patients who get care early in the week tend to get out of the hospital earlier than patients who get their surgeries done in the Thursday or Friday. And we saw that we not only did we see that there was a weekend effect in our elective colectomy patients, we saw that with the initiation of our tailored ERAS protocol, that weekend effect disappeared. So that patients who underwent surgery early in the week, when there was no ERAS, their average length of stay around 3 days, while people who underwent surgery later in the week, it was a day and a half longer. And after ERAS, that disparity was pretty much minimized. And then we became invested in looking at other patient-centered factors that haven't really been traditionally studied by surgeons in the past. And all these factors that we experience in our clinical practice that like really seem to affect a postoperative recovery. This is again done by Julie Hong. So we found that in Queens, living with family was associated with a significantly decreased length of stay and decreased risk of being discharged to a rehab or nursing facility. And distance from the hospital wasn't associated with prolonged lengths of stay because, in Queens, it's still in the transportation desert, so that kind of minimized the effect of distance, I guess. But this idea of social support was very important in our postoperative outcomes. So we kind of delved deeper there, and we kind of looked at area deprivation index, and looking deeper in social determinants of health and how that affected our outcomes. And the area deprivation index is a tool used to assess socioeconomic disadvantage within neighborhoods, and it considers factors like income, education, employment, and housing quality. The ADI is often used to identify areas with high levels of deprivation and can really help in resource allocation and addressing health disparities. And we found that, you know, in our map, this is where we are, this is where our hospital, we're kind of in the area where there's a lot of neighborhoods. We're surrounded by a lot of neighborhoods with in the red and orange where neighborhoods with high deprivation indexes. And while ADI can be arguably misleading in large cities with high housing costs, it gives us a way to quantify deprivation at the neighborhood level. And so we found that this is unpublished, but this is our data. It says that patients that come from from neighborhoods with high ADIs is associated with a lot longer length of stay after the elective surgery for colorectal cancer. The social vulnerability index, or SVI, is a tool to assess the relative social vulnerability of communities. It really sees how well a community can respond to and recover from threats to public health, like disease outbreaks in COVID, or natural disasters. It uses census data to calculate a score for each community based on factors like socioeconomic status, household characteristics, racial and ethnic minority status, and housing type. Whereas ADI is a single composite score. SVI is available in as an overall measure or as 4 submeasures: socioeconomic status, household characteristics, racial and ethnic minority status, and housing type and transportation. And so Aryeh Metzger, who's like an awesome research resident, he kind of analyzed the SVI and his association with ERAS, and we found that prescribing the ERAS medications was not associated with a decrease in post-op complications before the delivery protocol, but after the program began. But after the program began, it was associated with a overall odds ratio of 0.14. And so this could be due to increase in adherence among patients who were prescribed the ERAS meds from getting it delivered to their homes. And looking at factors associated with prolonged length of stay, we found that housing and transportation vulnerability was associated with an increased length of stay before we implemented the delivery program, but there was no association after we implemented the delivery program. So this is kind of an overall look of like what factors and quantitative ID of what factors lead to adverse outcomes after colon cancer surgery. And we kind of found it, we basically broke it down by a whole bunch of demographic and social determinants of health. And what we found was, being geriatric, um, being elderly, being having diabetes, and specifically having living in a neighborhood with high vulnerabilities to housing type and transportation, which means living in a multi-unit housing or crowded housing or having no vehicle at home or living in group quarters was associated with prolonged length stay after your elective cancer surgery. So I'm finishing up here, but so why does it all matter? So why does it matter to all of us? So it's important, especially important to me because this is where I grew up in, but we kind of all want to reduce morbidity and mortality for everybody, decreasing length of stay for everybody, reducing the risk of readmission for everybody. And overall, from a dollars perspective, like the overall delivery model, it was only about $93 on the high end for each patient to deliver these preoperative medications, as compared to, $11,000 for a day in the ICU, $2,000 for an extra day in a hospital, or $500 a day for nursing home or rehab stay. Even from a dollar standpoint, this makes sense. And so, what are our next steps here in Queens and in Cornell? We hope to expand this delivery program to other NYP sites. We're in the process of doing qualitative assessment on barriers to screening for colon cancer and for surgery for colon cancer. We're assessing not only the physiologic but also social frailty as a kind of a preoperative communication measure. And then we're hoping by asking these social frailty questions, we kind of activate the patient's social support preoperatively so that they can minimize minimize the issues postoperatively. And then from all this research, we also realized that our patient education materials, like trustworthy patient education materials, was something that we were all lacking. So, we were all working on improving patient education materials in regards to colorectal surgery and colorectal cancer in different languages. Okay, I think I'm done too. Any questions?
That is fantastic work. A lot of work over what period of time? How long have you been working? Is that 2017?
It started the 2017 was when we first started the ERAS protocol here with Chris and myself. Yeah.
Wow, that's definitely a lot of work. Obviously, that works only if there is support from the institution. So if you can quickly tell us how you convinced the C-suite to partner with you. The numbers at the end in terms of saving are very convincing, but I don't think you had those numbers ready at the very beginning.
No, and a lot of it was from a practical standpoint, we had to kind of appeal to dollar and cents. Like initially, a lot of this work was initiated by Chris Foglia before I got here, and a lot of it was basically based on like outcomes, like infection rates and stuff like that, which negatively impact like reimbursement rates. And Chris did a lot to kind of get Queens up to speed here. So appealing from a C-suite was kind of finding objective measures, namely, beds in the hospital, saving beds in the hospital, saving dollars and cents, and kind of really convincing them to like do a small investment for a long-term like savings at the end, because patient care, especially in our communities, requires a bit of nuance, and it really has to be tailored. So it's still a battle, it's still a battle, and to convince seeing for the forest for the trees, but it's kind of like it really is just appealing to with objective findings.
Yeah, and I also want to commend you for publishing your results because that's an important piece of information, not just to the C-suite, but also our patients, the patients that have access to publication and validates the work you've been doing. Any other questions from the panelists? Otherwise, we can stop this recording and start with the